Hi, Fatima Tuz Zahra here. I'm a hematology and oncology fellow at Moffitt Cancer Center and very excited here at ASH to be presenting our clinical project titled Outcomes of CD20 and CD3 bispecific antibody therapy as a holding or bridging therapy prior to chimeric antigen receptor T-cell infusion in aggressive B-cell lymphomas. Now, CAR T-cell therapy has been approved as a second line in relapsed or refractory aggressive B-cell lymphomas. Similarly, when we talk about CD20 and CD3 bispecific antibodies, they have also been approved. And both modalities we know are increasingly utilized in the lymphoma space. But what is not known as what is the role of these CD20 CD3 bispecific antibodies in patients in whom we use them as a bridge or hold therapy to take them to CAR T-cell therapy. So we analyzed a small cohort of patients at Moffitt just to put out some real world data that how these patients do on BiTEs, and then if they do good or bad on bispecific antibodies, could that also correlate to their outcomes with CAR T-cell therapy down the line. So to this end, we analyzed our bispecific antibody database. We had a total of 81 patients and in particular we selected those patients in whom ultimately they proceeded to CAR T, and the reason for giving bispecific antibody was just to use it as a bridge or hold therapy. We had 16 patients in total, majority of them were white and female. Now, this is a heavily pre-treated group of patients who are quite sick, and the fact that they even needed bispecific antibody prior to CAR T-cell therapy could signify that they had much aggressive biology of the disease. So keeping that in mind, we had 16 patients and we evaluated outcomes prior to CAR T, and in total group of 16 patients, unfortunately 3 passed away prior to receiving CAR T-cell therapy. 2 had amazing response to bispecific antibodies and they did not proceed to CAR T. 11 patients ultimately proceeded to CAR T. In those 11 patients who proceeded to CAR T, we only had response evaluation in only 10 patients. So for 1 patient, we did not have response evaluation. CAR T-cell products that were used were variable, but the most common was Axi-cell used in 8 patients. We had Lysocell used in 2 patients and Brexu-cell used in 1 patient. The bispecific antibody cycles ranged between, some people got 1, some people got 4 cycles, but the median was 2 for this small group of patients. 1 patient was in complete response prior to CAR T, 5 patients had a partial response prior to CAR T, and 4 patients were actually progressing at the time of being given CAR T. Now, what is most interesting in our real world data is that in those 4 patients who were progressing already on bispecific antibodies, unfortunately, 2 progressed after CAR T and 2 had a response to CAR T but very short-lived, that it was just about 3 months. And then finally we looked at the toxicity assessments and we found that out of these 11 patients who proceeded to CAR T, 9 had CRS and then 7 had ICANS toxicity. 45% patients actually had a grade 3 to 4 CAR T toxicity with ICANS. So this is a nice like swimmers plot where we have shown that how many bispecific antibody cycle patients received and which CAR T-cell therapy they eventually received. So these 2 patients highlight the patients who did not receive CAR T-cell therapy and were continued on their bispecific antibody treatment. So basically, to conclude, I would say that this is a very small real-world cohort study which shows that what is the real-world outcome of patients in whom we can utilize bispecific antibodies as a bridge or hold therapy to CAR T. Now, interestingly, what we have shown that if you had a very good response to bispecific antibodies, this correlates with ongoing good response to CAR T-cell therapy. And however, unfortunately, if you did not respond well to bispecific antibody therapy, this also correlated with having a poor response to CAR T-cell therapy. So in the future or prospective trials or expanding the study into a multi-institutional study, our hope will be is to determine can the response to bispecific antibody serve as a biomarker of eventual response to CAR T-cell therapy. So this is something we'll be looking at. The other thing is we did have a very high ICANS rate in this population. Perhaps this was driven by high tumor bulk or CNS involvement, which was seen in 4 patients in this subgroup, or potentially that bispecific antibodies are somehow immune priming the tumor microenvironment and leading to higher ICANS toxicity when ultimately the CAR T-cell therapy is driven. But this is all theoretical at this point. We will need more patients to elucidate that.